As we look in the past, most of the drugs we've used for the treatment of migraine have been discovered by accident. So a patient was getting a drug for another disorder, and by accident, we found out that it helped their migraines. For the first time, we have a drug based on science. We've known that CGRP is intimately involved in migraine pathogenesis. We know that if you infuse CGRP, you can bring on a migraine attack. Now we have drugs that target both CGRP and its receptor that have been shown to be safe and effective for the prevention of migraine. When we talk about treatment of a specific disorder, we can talk about two things. So for example, you have a beta blocker for the treatment of hypertension. We know it works by blocking the beta adrenergic receptor. If we talk about drugs for the treatment of epilepsy, we don't talk about mechanisms. We talk about the fact that in an animal model of epilepsy, it stopped the seizures. So there are many different drugs that can stop seizures, but only some of them can work for migraine. So sort of by accident, we discovered them. But we know is it's not related to the fact they work for epilepsy, but it's due to the same mechanism that works for epilepsy works for migraine. The two drugs that have been shown in placebo-controlled double-blind trials and FDA approved for the treatment of migraine are divalproex sodium and topiramate. They continue to be used for the treatment of migraine, and they will continue to be used in the future. In order to get many of the new treatments, one has to fail approved medications, and those are two of the medications that have to be tried before moving on to advanced medications. The major problem we have today with the use of cannabinoids in the treatment of migraine is the lack of controlled trials. It is still illegal to use cannabinoids in the United States, and it's extremely difficult to do controlled trials for many reasons. One, marijuana is not marijuana. They differ in their THC and CBD content, and they differ in their terpene content. So you can standardize treatment, you cannot have standardized protocols. Number two, we don't know much about which type of marijuana to use. Is it CBD alone? Is it THC? We know that CBD alone is used for the treatment of Dravet syndrome. So therefore, when somebody tells you that marijuana worked or didn't work, we don't know what marijuana they're using. I think it works. I can't prove it, but we need well-designed trials using standardized formulations. The most exciting developments in migraine preventive treatment are the development of drugs targeted against CGRP and its receptor. We now have a mechanism-based treatment that works. I think, to me, the most exciting part of this AAN meeting is the appearance of booths devoted to the diagnosis and treatment of migraine. For years, we didn't see anybody with an interest in headache or migraine disorders, and all of a sudden, every other row, somebody shows an interest in migraine. It's one of the most disabling disorders known to mankind, and we didn't have any new treatments for a long time, but that's changed.